Hello, my name is Kevin and I'll be your conference operator today. At this time, I would like to welcome everyone to the APRN Full Practice Authority Evidence Conference. All lines have been placed on mute to prevent any background noise, and after our presenters' remarks, there will be a question and answer session. If you would like to ask a question during that time, simply press star, then the number 1 on your telephone keypad. I would now like to turn the conference over to Andrea Broussard. Please go ahead.
Thank you so much, Kevin. Good afternoon and welcome. Thank you all for taking time to join us for today's webinar. Before we go too much further, I want to mention that we are recording today's webinar, so if you miss a section or would like to pass it on to a colleague, you can find the recording later this week by going to www.campaignforaction.org/webinars. Also, we will be taking questions over the phone at the end of the webinar, but you can type questions throughout the webinar using the chat function. Be sure to send your question to everyone. Today's webinar builds on 2 prior CCNA webinars, and I hope that some of you attended our previous webinars on increasing access to advanced practice registered nurse care. And I would like to thank researcher Joanne Spetz, who was the presenter on both of our prior webinars. Today's webinar will present new evidence, identify evidence gaps, and will discuss continued need for evidence and stories. In a few minutes, I will introduce Dr. Heather Braun, who will present new research. Heather is a postdoctoral research fellow at Penn, and she'll tell us a little bit about her research, and she's a certified nurse practitioner. And then after Heather presents the new evidence, we're going to ask Dr. Deanna Grimes to respond to the evidence. Deanna Grimes has done research in this area for many, many years, and she's a clinical nurse specialist in community health nursing. And now, Heather, please summarize the latest evidence.
All right, thank you, Andrea. I'm pleased to be with all of you today to share a summary of the most recent research findings regarding APRN scope of practice and to share with you some of my own work on the topic. These high-quality studies utilize a variety of data sources and have been conducted by interdisciplinary teams, including nurses, physicians, economists, and health services researchers, and published in high-impact journals like Health Affairs and Medical Care. We'll start with some recent work regarding access to APRNs. First, Martzloff and colleagues published their findings regarding the relationship between state policy and anesthesia provider supply in rural communities and medical care in 2019. The Centers for Medicare and Medicaid Services Conditions of Participation require that CRNAs be supervised either by an operating physician or have an anesthesiologist immediately available on the premise. However, state governors have been allowed to opt out of this requirement since 2001, and as of 2018, 17 states have done so. Using 2010 to 2015 county-level data from the Area Health Resource Files, Martzloff and colleagues examined counts of anesthesia providers per 100,000 people and categorized states by their opt-out status from the CMS physician supervision requirements and scope of practice, creating 3 distinct groups. First was high restrictive scope of practice, non-opt-out states. The second, medium to low restrictive scope of practice, non-opt-out states. And third, medium to low restrictive scope of practice, opt-out states. Of note, there were no states that were high restrictive scope of practice, opt-out. In their analysis, they controlled for a variety of factors, including the local availability of anesthesia provider training, other healthcare-related characteristics, and local economic conditions, and other community characteristics that might attract health providers to a county. They found on average that there were 13.4 anesthesia providers per 100,000 people in the U.S., and of those, 4.7 were anesthesiologists and 8.7 were CRNAs. 37% of counties were classified as rural across the U.S., and compared to non-rural counties, those rural counties had significantly fewer anesthesia providers, 7.7 versus 16.4 per 100,000 people. And in these rural counties, CRNAs represented 80% of all anesthesia providers. 32% of counties were medium or low restrictive scope and opt-out, 28% were low or medium restrictive scope and non-opt-out, and 41% were high restrictive scope and non-opt-out states. And states that were in the Mid-Atlantic and Southeast had the most restrictive regulations, while those in the West had the least. They found that opt-out status was correlated with a greater supply of CRNAs in rural communities and a significantly greater number of CRNAs in rural counties with no anesthesiologists compared to more restrictive scope of practice states. This finding is particularly important because over 80% of rural counties have 0 anesthesiologists. They found more anesthesiologists in rural counties and states that did not opt out, supports their idea that states opt out as a result of greater reliance on CRNAs. And Martzoff and colleagues conclude that state regulations may lead to increased supply of CRNAs in rural communities. In their JAMA 2019 publications, Yu, Smith, and Spetz examined primary care NP and physician distribution in low-income and rural areas. They used data from the 2010 to 2016 National Provider Identification Registry to count primary care NPs and the American Medical Association Physician Master File to count primary care physicians. They calculated provider counts per 100,000 for health services areas, and from 2010 to 2016, they found that the number of primary care NPs, more than doubled from around 59,000 to over 123,000, as the number of primary care physicians only slightly increased during that time, from about 225,000 to 243,000. When examined over population income quartiles, which is defined as the percent of population at or below 138% of the federal poverty line, the number of NPs per 100,000 population increased by a mean of 15.3 in the highest income, but up to 21.4 in the lowest income quartile, while the physician supply remained constant. The primary care NP supply increased the most compared to the physician supply in rural counties by an annual mean of 4.3 in rural and 2.9 in metropolitan areas per 100,000 population, so that by 2016, the highest NP supply was observed in rural health services areas and the highest physician supply in metropolitan areas. Zhu and colleagues demonstrate a narrowing gap between primary care NP and physician workforces over time, particularly in low-income and rural areas. This growing supply of NPs may offset low physician supply in these areas and increase primary care capacity in underserved areas. Barnes, Richard, McHugh, and Martzoff published in Health Affairs in 2018 their findings regarding rural and non-rural primary care physician and NP supply. Using SKNA provider files for 2008 to 2016, Barnes and colleagues examined the extent to which NPs were working with primary care physician practices in rural and non-rural settings. SKNA is a commercial data set that includes practice-level characteristics of office-based physician practices nationwide. They classified states by their scope of practice as restricted, reduced, or full, based on requirements for collaborative agreements. And they found a growing presence of NPs among rural practices, with a 43% increase between 2008 and 2016, as physicians saw a relative decrease of 13% during the same time period, though they were still the largest proportion of providers in rural areas. Across all years, a significantly higher percentage of rural practices employed at least one NP compared to non-rural practices, and the presence of NPs increased in rural practices from 31 to 43%, and in non-rural areas from 18 to 26%, as did the average number of NPs in practice, increasing from 1.3 to 1.6 in rural and 1.5 to 1.7 in non-rural. From 2008 to 2016, states with full scope of practices had the highest percentage of practices with NPs. In rural practices, the relative increase in practices with NPs was 30% for full, 50% for reduced, and 41% for restricted scope states. Growth also occurred in non-rural practices within each scope of practice group, but the levels remained below that of rural practices. States with full scope of practice had the highest NP presence, which increased from 35 to 46%, but the fastest growth occurred in reduced and restricted scope of practice states. Of note, one limitation of this data source is that it does not account for independent NP practices. so NPs practicing in full scope of practice states are likely undercounted. However, there does not exist a comprehensive data set to capture these practices. We have additional evidence also supporting the link between full scope of practice for APRNs and utilization and care quality. Trzynski and Yoldova published their findings in the Journal of Health Economics in 2018. They used 1996 to 2012 data from the Medical Expenditures Panel Survey, or MEPS, to assess healthcare utilization and health outcomes to conduct an economic analysis using a difference in difference approach. They determined scope of practice as to whether the state had full practice authority or not, and their analyses accounted for a variety of factors, including patient characteristics, provider supply, inpatient and outpatient visits, number of medical schools, and the political affiliation of the governor. They found that after NPs achieved full practice authority in a state, that the probability that an adult had a checkup in the last year increased by 3.3%. Also, more patients reported lower indirect costs when the state achieved full practice authority. More patients reported having a usual source of care and reported visits to be of higher quality when their state achieved full practice authority for NPs. Additionally, more patients reported being in excellent health status and had fewer emergency department visits for ambulatory care-sensitive conditions. McMichael, Spetz, and Bierhaus in 2019 published their findings in medical care. They used data from 2006 to 2015 from the FAST-STATS database, which is an early access aggregated version of the state emergency department databases and state inpatient database, which is compiled by AHRQ. States were categorized as to whether NPs required any oversight or collaboration with physicians. 15 states were included in the analysis that also expanded Medicaid and participated in the FAST-STATS database. All 15 states saw an increase in ED visits following Medicaid expansion, but states that required physician oversight experienced larger increases in the number of ED visits by Medicaid beneficiaries. In states that required physician oversight, ED use increased by approximately 28%, and in states that did not require physician oversight, ED use only increased by 7%. They and others concluded that this smaller increase in ED visits in full scope of practice states is related to the increased access to primary care. Neff and colleagues published their findings regarding NP regulations and population access to care and Nursing Outlook in 2018 by examining NP scope of practice and travel time to PCP. Data sources included the AMA Master File for Physicians and the 2013 membership for the American Association of Nurse Practitioners. The dependent variable in their analysis was the proportion of the population with a greater than 30-minute drive time using the 2012 census block as the unit of observation. States with independent NP practice had 19% lower odds of having greater than 30-minute drive to the closest NP or MD as a proxy for better access to care. Smith and Gagan and colleagues in 2019 published their findings in the Journal of Epidemiology and Community Health. They used the Nurse Practitioner Annual Legislative Updates to identify states with full practice authority and when the law passed. They linked state scope of practice to Medicare's SEER data for the patients diagnosed with cervical cancer between 2010 and 2014. 12 states were included in the study, half had full practice and half were restricted. Among states with reduced scope of practice, women in medically underserved areas have a twofold higher odds of being diagnosed with late-stage cervical cancer, relative to women living in areas that are not medically underserved. However, among states with full scope of practice, there were no late-stage diagnosis disparities among women living in medically underserved areas and those who did not. Davis and colleagues published their findings in the Journal of Internal Medicine in 2018. They linked providers in the 2014 National Plan and Provider Enumeration System to Medicare claims to identify active providers and counted the total number of adult primary care physicians, NPs, physician assistants, and chiropractors, and included county-level characteristics from the 2010 census. County-level life expectancy was used to measure health status, and county-level median household income to measure SES. Both were collapsed into quartiles. In their data, they identified approximately 272,000 primary care physicians and 63,000 nurse practitioners. The unadjusted rate of providers, including physicians, PAs, and chiropractors, increased across all levels of socioeconomic and health status, but this was not the trend for nurse practitioners. Adjusting for county-level differences, the supply of primary care physicians, PAs, and chiropractors increased across socioeconomic status. However, NPs were less likely to be in areas with higher health status and did not vary across SES and providing care, and were found to be providing care in higher need areas. Continuing the evidence of scope of practice and care outcomes, McMichael's forthcoming 2020 publication in the 95 Indiana Law Journal, he analyzed a data set of over 69 million births in the National Vital Statistics System over an 18-year period from 1998 to 2015. Results demonstrated that relaxing scope of practice laws for APRNs significantly reduced C-section rates, which is currently over 3 times the rate recommended by the World Health Organization. And medical inductions of labor were also reduced when malpractice liability risk was also low. However, when malpractice liability risk is high, relaxing of scope of practice laws did not change the C-section or medical inductions of labor rates, kind of showing this relationship between these policies. When attending Academy Health's annual research meeting this year, there were several research findings regarding APRNs and scope of practice. Patel and Kandrick presented their findings using data from the National Ambulatory Medical Care Survey from 2011 to 2015. They examined whether the number of services provided by provider type was different, as some have raised concerns that APRNs are more likely to overuse services compared to physicians due to differences in training. They examined visits where patients were only seen either by an NP, a certified nurse midwife, or a physician, so they did not include joint visits in their analysis. They found no differences in the number of services provided by APRNs and physicians in ambulatory visits overall or in primary care visits. Specifically for visits coded as general medical exams with APRNs, they were associated with 1.2 fewer services provided on average relative to general medical exams that were provided by physicians. In the American Journal of Medicine, Yang and colleagues published their findings in 2018. Using data from the Veterans Health Administration, they compared outcomes of over 19,000 newly diagnosed diabetic patients cared for by physicians and examined their outcomes over 4 years. Of note, in the VA from 2005 to 2010, up to 29% of primary care visits were provided solely by NPs and PAs. They found that diabetic management was comparable among all 3 provider types across the 4 years. And the longitudinal nature of the study and studying providers in a system that has similar responsibilities or strengths of the study. Also at Academy Health's annual research meeting, O'Reilly, Jacob, Perloff, and Brierhouse in 2019 presented their findings, examining the rates of low-value back images ordered by primary care physicians and NPs. This is of importance to study because the Choosing Wisely campaign recommends against imaging for uncomplicated back pain. They evaluated Medicare Part B claims of over 45,000 beneficiaries from a nationally representative sample in 2012 and 2013. Who had an encounter for an uncomplicated acute low back pain and were seen by a primary care NP or primary care physician. They found that primary care physicians and NPs ordered low-value back images at similar rates. Bierhaus and colleagues provide additional support for the quality of primary care NPs in their 2018 medical care paper. Using Medicare claims data from almost 300,000 beneficiaries in 2012 to 2013, they examined differences in quality of care provided by primary care NPs and primary care physicians, or care provided jointly by primary care NPs and physicians. Beneficiaries with a disability, dually eligible for Medicaid and Medicare, and those living in rural areas were more likely to be cared for by NPs. They were also less likely to have hospital admissions, readmissions within 30 days, inappropriate ED visits, and fewer low-value MRIs associated with low back pain. Beneficiaries cared for by physicians were more likely to receive chronic disease management services for diabetes, coronary artery disease, and COPD, and cancer screening. Potential causes for these differences might be NPs' access to organizational supports, or requirements for physicians to order screening, and differences in beneficiaries' access to technology, particularly in rural areas, or differences in clinician incentives. For example, services might be billed under the physician as Incident 2, but actually provided by the NP, which is a limitation of this study and using Medicare claims in this work in general. Quality of care for beneficiaries jointly cared for by NPs and physicians generally scored in the middle of NP and physician primary care, with the exception of cancer screening, in which screening rates improved when joint care was provided. And really more work is needed to understand how teamwork affects these care outcomes. With regards to collaborative agreements, we have recent evidence to suggest that they are costly to both APRNs and consumers. Martin and Alexander published their findings in the Journal for Nursing Regulation in 2019. The regulatory landscape for APRNs may present challenges as APRNs and their patients differ based on geographic location, and these differing regulations compound pre-existing inequities in care by creating additional barriers to access for underserved and vulnerable populations. Collaborative practice agreements required in states without full practice authority vary greatly with regards to financial and professional requirements. The National Council of State Boards of Nursing designed a cross-sectional study to identify APRN practice trends in states that require a CPA or collaborative practice agreement. They surveyed over 8,000 APRNs practicing in 29 states that mandate reduced scope of practice on at least one APRN role. Only half of APRNs indicated that they communicated in person with their supervising physician at least once a month, with 61% communicating via text, phone, or email at least once per month. 57% report that their physician conducts medical record reviews, and 20% of APRNs reported that they personally or their facility had to pay a fee to a collaborating physician. Of those 20% who pay a fee, 18% paid directly out of pocket to establish a CPA, and 21% paid directly out of pocket to maintain their CPA. Those paying a fee were primarily nurse practitioners, and half worked in primary care. The median fee to establish a CPA was $650. However, fees ranged considerably from $10 to $50,000. The median fee to maintain the CPA was $500 per month, again with a big range of $4 to $4,167 per month. APRNs working in rural settings were 52% more likely to report needing to pay a fee to establish or maintain their CPA, and those working remotely from their physician were 2.7 times more likely to report a required fee for their CPA. APRNs practicing in large health facilities, private practices run by physicians, or those who were self-employed were less likely to pay CPA fees compared to those practicing in private practice settings established and maintained by APRNs. 1/3 of respondents reported that certain terms of their CPA restricted their care of patients, such as restrictions to prescribing, procedures, patient panels that they could see, and distance or setting requirements. As part of her dissertation at Penn and presented at Academy Health in 2019, Ritter examined the variation of collaborative practice agreements. She undertook a survey of 1,611 Florida nurse practitioners, a state with restricted scope of practice. She found, in general, that CPAs included vague language, and 24% of NPs reported no terms of physician collaboration in their agreement, and that 25% also contained no terms for on-site or off-site supervision or documentation review. 9.2% of NPs reported paying a physician for the CPA with a median cost of $725 per month, accounting for 10% of the NP's annual salary. Among those NPs who pay for their CPA, 37% report that the CPA contains no terms for collaboration, and 50% of self-employed NPs paid for their CPA, compared to 6.2% of non-self-employed NPs. Furthermore, McMichael, in his forthcoming 2020 Indiana law publication, found that the supervising physician may be held liable for APRN malpractice under the theory of respondent superior, or Latin for let the master answer, or the negligent supervision doctrine. He writes that restrictive scope of practice laws can increase the malpractice liability risk of physicians and decrease this risk for APRNs and PAs via several traditional tort doctrines, and that these restrictive scope of practice laws may indirectly aid patients in holding physicians liable. This, together with the evidence from Martin and Ritter, calls further into question how collaborative agreements are aiding NPs and physicians in providing optimal patient care. In the Journal for Nurse Practitioners in 2018, our co-presenter Deanna Grimes and colleagues published their findings. Their objective was to examine whether states with least restrictions on scope of practice for APRNs had patient outcomes inferior to patient outcomes in the most restrictive states, as evidenced by hypertension and diabetes management. They categorized scope of practice restriction based on work from the Future of Nursing that classified states by physician involvement in care provided by NPs with 4 categories. First, physician involvement for prescribing. Second, on-site oversight. Third, quantitative requirements for physician chart review. And fourth, maximum NP to physician ratios. 6 states required all 4 of these activities at the time, and 10 states did not restrict NPs in any category. They conducted a cross-sectional analysis of publicly available state-level data from FQHCs in 2013. FQHCs were studied because they serve a large number of similar vulnerable populations and adhere to similar policies nationwide with regards to staffing and services offered. There were 146 FQHCs in the 6 most restrictive states and 157 in the 10 least restrictive states. In the most restrictive states, 28% of visits were to NPs, and in the least restrictive, 25% of visits were to NPs. They found that there were slightly more patients that were controlled by their hypertension and diabetes in least restrictive states, with a similar pattern for diabetic control. So despite the evidence, to date, only 22 states plus Washington, D.C. have full practice authority. As part of my dissertation, I was curious as to how the passage of the Affordable Care Act impacted expansion of NP scope of practice. I undertook a descriptive policy analysis using annual legislative reports on NP legislation and state-level legislative and media coverage. To date, 9 states have adopted full scope of practice legislation since ACA passage, representing a more than doubling of states passing such legislation compared to the prior 10 years. 7 of these states also expanded Medicaid in 2014, and I could find that 7 had made mention specifically of the ACA or access to care concerns in favor of passing full practice authority legislation. There wasn't a consistent makeup of party affiliation, a state legislature, or bill sponsorship, and there was a wide range of interest groups involved, including AARP's Campaign for Action. There was evidence that studies on NP outcomes and data from their own states regarding provider shortages helped supporters move this legislation forward. Additionally, capitalizing on support from elected officials or those with a personal connection to NP care was also helpful. Framing the need for regulatory change and centering the discourse beyond the benefit of the profession to that of the public makes way for a broader political interest and participation and passage of full practice authority. So on this next slide here, it's an updated map of the NP scope of practice legislation since the Campaign for Action began. As you can see at the bottom in the legend, the light green indicates states where full scope of practice was achieved prior to the campaign. The dark green indicates states where full practice was achieved since the campaign began. Brown states are states that have made substantial improvements, and yellow where states have made incremental improvements. The years when full scope and substantial improvements have been made are indicated in the map as well, and we also include a hyperlink below so that you can check for updates. I'd like to quickly highlight the 6 states that have passed legislation that substantially improved APRN scope of practice. Kentucky in 2014 passed Senate Bill 7 that allowed APRNs with 4+ years experience to prescribe routine medications without a written agreement with a physician. However, written agreement is still required for prescribing controlled substances. Passage of this legislation was in reaction to increased health insurance enrollment through Kentucky's Health Insurance Exchange website, coupled with the majority of counties, 73%, having partial or full designation as primary care health professional shortage areas. New York also in 2014 passed Senate Bill S4611A, called the Nurse Practitioners Modernization Act, that eliminated the need for a signed written practice agreement for NPs with over 3,600 hours of practice. Written practice agreement between NPs with less hours than a physician is still required, and NPs maintain collaborative relationships with physicians. In 2015, Delaware passed Senate Bill 57, where APRNs could apply for independent practice once they completed at least 2 years of practice and 4,000 practice hours. In Utah in 2013, the Utah Action Coalition for Health persuaded state legislators to expand Medicaid reimbursement from just family health and pediatrics to other NP specialties such as adult health, geriatrics, women's health, and psych mental health. And in 2016, Senate Bill 58 allowed APRNs to prescribe Schedule II medications without a consultation and referral plan. West Virginia in 2016 passed House Bill 4334, which removed the restrictive requirement for a collaborative agreement with a physician after 3 years of APRN practice, expanded the prescribing formulary for APRNs, and permits APRNs to sign documents previously only allowed by physicians. It also retired the individual practices of nurse midwives and certified nurse anesthetists to bring them under one APRN designation. Again, this is expanding access to care in a state where 50 of 55 counties are considered underserved healthcare areas by allowing APRNs to open practices where previously APRN practices were closing due to a lack of physicians to sign collaborative agreements. Finally, in 2017, Illinois signed House Bill 313, which went into effect in 2018. This enables APRNs who work outside of hospital settings and meet certain conditions to practice without a written agreement with a physician, but their ability to prescribe certain medications remains limited. APRNs who've completed 4,000 hours of clinical experience with a physician and 250 hours of continuing education will be able to practice without a written agreement, except a written agreement remains for substances that have high abuse potential, such as opioids. Finally, Mark and Patel bring together many of these research findings and ask, where do we go? We know that the growth of the NP workforce is much greater compared to physicians and projected to continue to be that way through 2030, and that restricted scope of practice regulations are an anti-competitive barrier for primary care providers. States with full scope of practice have more and faster NP growth, including in rural areas and primary health professional shortage counties. Additionally, NPs are more likely to care for underserved populations, and there is evidence to support that full scope of practice is associated with improved utilization of services, and most importantly, that restrictive scope of practice does not increase quality. Removing restrictive scope of practice regulations could result in increased access to care. Regardless of research demonstrating that restricted scope of practice does not improve care quality, and despite access to care needs, we find that implementation of full scope of practice legislation is more political, and our voices are needed even more. Mark and Patel call for better data infrastructures. For example, we've previously mentioned the issues with Incident 2 billing and Medicare claims, and just this year, MedPAC has recommended that CMS eliminate Incident 2 billing to better capture care provided by APRNs and physician assistants, as well as to add more specialty information about APRNs and PAs who practice in a variety of specialties. As researchers, they also encourage us to consider new study designs, such as quasi-experimental designs, leveraging state or system-level changes as natural experiments to evaluate how improvement in scope of practice may influence patient outcomes. And now I'd like to turn the presentation back to Andrea.
We recently saw criticism of the IOM report on social media. Dr. Strange said on Twitter that the IOM report was funded by nursing groups and the research is either biased or of sufficiently low quality that it precludes any valid conclusion. So I'd like to respond to the research and respond to Dr. Strange and just to alert you that the detractors are out there. Dr. Strange cited a 2014 evidence brief that was prepared for the Veterans Health Administration, saying that the APRN research in the IOM report is low quality. So let's respond. As far as bias, the IOM report was funded by the Robert Wood Johnson Foundation. Robert Wood Johnson Foundation is not a nursing group. Robert Wood Johnson Foundation funds lots of health providers. Sue Hausmiller and the IOM committee ensured that the research studies were high quality and not biased. As far as the quality of evidence, the strength of evidence in the study cited in the IOM report were as strong as possible. We haven't had recent randomized controlled trials, and there were some observational studies. But all the studies cited showed no difference favoring either APRN or physician care. It was comparable. And the Veterans Health Administration funded brief, at the bottom, there's a disclaimer that says, this does not represent the views of the Veterans Health Administration. So as we've been working on increasing access to care and we monitor legislation throughout the states, we hear policymakers ask questions about the evidence. Has access improved in states that enacted full practice authority? We really don't know yet, but in terms of the second bullet, we do know that APRNs have migrated from restricted states to full practice authority states. We know that in the 5 years that Nevada achieved full practice authority, the number of APRNs has doubled. How does restricted practice affect patients? We don't know. Nurses are so good at workarounds. We get the form signed, so there are no noticeable delays. This includes the forms for home health services. We get them to a collaborating or a physician that we work with to get them signed. This is the area where we need your stories. How does restricted practice affect patients? So before I turn it over to Dr. Grimes, I'd like to say that the handouts, there's 2 handouts for this webinar that are available on our webpage already. One handout is just a one-pager. Recent studies demonstrate important roles of APRNs in access, quality, and cost. And that just has some bullets that you can use for your messaging with some references on the back. And then we have a full handout, APRN Full Practice Authority Evidence, and that has the references for all of these studies that Heather talked about in this webinar. So they're all available for you. Unfortunately, we can't share all the actual articles, but I know that many of you have access to universities. So turning it over to Dr. Deanna Grimes, please comment on the new research findings that Dr. Braun shared. How should we use this evidence?
Well, first off, I want to thank Dr. Braun for a very thorough and up-to-date review of the evidence on APRN practice. And this review is a culmination of the decades of research that has shown that APRNs provide high-quality care for lower cost, improve access to care, particularly in rural and underserved areas. Patient satisfaction is always high in these studies when that is studied, and full practice authority increases the number of APRNs in an area. And this is a significant finding today when we're finding we need more primary care providers. How do we use this evidence? Well, I looked back over the years, and I started doing some research in this area in the early 90s, and we really have done a good job of publishing our findings, our studies, going back to 1990, 95, and up to today, and the research that Dr. Braun cited. The publications are complete. They're good quality. A lot of them are in nursing journals, but also in medical journals, and increasing over the years. I've seen them published in health service research journals, public health and epidemiology journals, health affairs, etc. So we're getting the word out, and I think that the researchers have done a good job of doing that. But in effect, we're talking to each other. We're talking to other professionals, and we've got to do that. I mean, that's important. But I really was struck with Dr. Braun's paper on, let me see if I can get the right title here, Leveraging Healthcare Reform to Accelerate Nurse Practitioner Full Practice Authority, in which she spoke about the interested parties, those that are interested in change and have something to gain or lose because of the issue of change. Long ago in my public health days, we talked about stakeholders in the community who had something to gain or lose if some policy was passed or some program was implemented. And it was the stakeholders who really helped us make change. And I could talk for an hour just about the influence that community members or small organizations or large organizations have had with community health. So I'm going to propose that besides publishing our research and moving more in this direction, I think about full practice authority and the impact of that and how we get there, I'm going to suggest that we think long and hard about who the stakeholders are if APRNs are to achieve full practice authority, or who would be impacted when APRNs don't receive that. And my thoughts are looking at, who are the groups that might influence state legislators. And so I think about not only the nursing organizations and certainly the state boards of nursing that have brought about good change, but also insurance companies and the pharmaceutical companies who run primary care clinics, or the healthcare administrators in a community or state. And that group is very large and can expand to a lot of even subgroups within that group. The industries who run employee health services, they are stakeholders. The neighborhood health centers and the public health agencies that run those neighborhood health centers. The companies that administer nursing homes or extended care facilities or home health care agencies, they are stakeholders. School districts that run school-based clinics. And I'm sure our audience can come up with hundreds more. Those are just on the tip of my tongue today. But I'm thinking that I'd like to see us not only publish in our professional journals, but also get those talking points out to the stakeholders in the states who can influence legislators. I was impressed with a statement in Dr. Braun's paper about, state legislators want to be reelected, and we are seeing a lot of that in our current governmental issues, and I'm wondering if we could have some communication at some point about who in these smaller organizations, or maybe not even smaller organizations, they may be very large and influential, but how can they influence our state legislators so that this change in full practice authority will come about? And that sounds like a heavy burden for the future, but we've been at this a long time. It might be fun to kind of reach out beyond, like I say, beyond our professional organizations and our professional literature to try to get the talking points out into the community. Thanks for letting me say that.
Thank you. Thank you so much, Deanna. We're now going to turn it over to the audience and ask you what questions, comments, or reactions do you have? And the other big question is, do we have enough evidence? If not, what evidence do we need? And I'll take a personal point here is, for all the D&P students out there who are doing projects, don't do them in vacuums. Join up with other researchers. So, Kevin, if you could tell our audience how to ask a question.
As a reminder, if you would like to ask a question, just press *1 on your telephone keypad. Again, that is *1 to ask a question.
Oh, and you can also use the chat feature to send everyone a question. We'll wait a minute for questions. I know we have some researchers on the line.
Your first question comes from the line of Laura Smith.
Okay, Laura, go ahead.
How do you get the handouts? I don't see them on the WebEx.
Sure. The handouts aren't on the WebEx itself. The handouts are on our Campaign for Action page. Campaign for Action / Full Practice Authority evidence.
Okay. Thank you.
And your next question comes from the line of Suzanne Wertman.
Suzanne, thank you. Please ask your question.
Hi, thanks so much. I'm curious about the evidence that we have for nurse midwives, particularly the research from Katie Cosmanil from the University of Minnesota, and the research from Saraswati Bedam at the University of, Canada. She's in Canada, Vancouver. So there's some clear evidence that increasing full practice authority for nurse midwives will actually improve outcomes, and I feel like that's a huge part of our push right now, particularly with the nation's focus on maternal health outcomes. So I wanted to hear what the researchers have to say about that. Thanks.
So, Suzanne, are you calling our attention to two other sources?
Yeah, I was surprised that they got a lot of press. Again, I was thinking about what Dr. Grimes said. We talk to each other. So they're two bits of research that are pretty prominent in maternal health circles. But I'm just wondering how we include that.
Are they recent? Do you know when they were released?
Absolutely. Yep. Absolutely. Dr. Cosmanil has been working for probably about the past 5 to 10 years on this, particularly looking at rural outcomes. And she's published in Health Affairs. Also, Dr. Vedam has a website where she she's got her findings, and they were on PLOS1. I think it was last year.
So I'm happy to talk with you offline and to get something out. We could add it to the handout. Kevin, are there other questions on the phone?
Yes. Your next question comes from the line of Lisa Hardy-McPherson.
Hi. Lisa.
Hi, good afternoon. So I'll preface my comments with my role. I serve as the Vice President of Government Relations for Northern Light Health here in Maine, and I'm a registered nurse. And I also have spent over 20 years working at the Maine legislature as well as Congress on a variety of legislative issues. So we are fortunate to have full scope of practice for our advanced practice nurses, our nurse practitioners. We're not quite there yet for the nurse anesthetists. And so as I listen to some discussion around political strategy, I just have a few ideas that I would offer. If there is research in this area, I'm not aware of it. But I think, we know the challenge that the Medical Association presents when I'm before various committees at the State House. And I'm not aware of any research that's been funded that looks at the medical community, particularly primary care providers, and their perceptions and sense of the role of advanced practice nursing in their practices, in their communities, in their state. But I think one political strategy that we need is to call the doctors on the carpet for the practice that's very well established and very well accepted by their colleagues around the country. So that's thought one. Thought two is the National Conference of State Legislatures is a resource for all state legislatures in the country, and they've published information for legislators on full scope of practice for advanced practice nurses in rural America. I don't think we fully leverage them as a resource in being at their conferences and so forth on this message. And then the third idea I have, and I've seen this in practice in other policy areas, the medical associations generally have full-time lobbyists that are very powerful and influential, and nursing organizations in states don't consistently have that. And for those states where we want this to be accomplished, I think there needs to be funding to pay for the expertise in terms of advocacy and lobbying to get it done.
All good points, Lisa, and thank you. The National Council of State Legislatures is meeting as we speak. And I will say, as far as lobbyists, the states where we have been successful have come up with the money for lobbying, or they have really done grassroots with their nurses so that their nurses were like lobbyists. They were there at the State House that often. I think we need to take advantage of APRNs who have cared for legislators to highlight that. I'd like to reply to some of the chat. We have critical care NPs at the University Medical Center in New Orleans who are desperate to demonstrate their worth and improvement in patient outcomes. How do we best advocate for practicing to the extent of our scopes is there current evidence to support our venture? I would say it would be looking for models in other states that have full practice authority. Sandra Cotton asks, in general, will more evidence really help? Is it more a matter of political will influence? I think you're absolutely right, political will and influence, but we need to have the evidence for when we have hearings and there's questions about the quality and safety and the cost. Peter Ronicky said the data on costs of mandated contracts is very useful. Other researchers could do the same kind of evidence gathering in key states like California, Texas, and other states actively considering full practice legislation. And wow, I'm thinking that would be a great PhD dissertation or a group project for DNPs. Okay, for Dr. Braun and Dr. Grimes, what are some of the future areas of APRN research that will build on the evidence, particularly, Heather, that you presented today? As you went through these, talking about the recent studies, was there evidence that we don't have that jumped out to you?
Oh, yes, I think that's a great question. So thank you, Hillary, for that. I think what I really am struck by is I think we're doing a lot more work around kind of looking at, using multiple years, kind of looking at longitudinally how kind of a chaining full practice authorities is sort of shifting, whether it's the supply of providers and access and things. But I think kind of really sort of trying to do a little bit more of these kind of policy analysis, and especially now that we've got the momentum, of states passing full scope in the last 10 years or so, that I think we could see a little bit more kind of showing some of the work that Trzynski and Yoldova did at looking at kind of what happened to states that passed that full practice authority. I think that that was kind of a more nuanced analysis with the difference in difference and published in a journal of health economics, but kind of thinking of ways that we can make those kind of findings more accessible, I think will also help people who are in the policy world trying to make these changes happen and being able to communicate them in a way, and hopefully also continuing to push for data sources that are going to be representative of the care that we provide. So if we're able to either eliminate the incident to billing or be able to provide a field to identify the provider giving the care that day, I think those would also be kind of big improvements in a way to gather kind of more evidence.
Thank you. Deanna, as you thought about the current research, are there gaps that stick out for you?
I didn't see any, but it'll probably come to me in the middle of the night. But I would add to what Dr. Braun just said with maybe we need some more interdisciplinary research in this area. In other words, when I look at the authors of, and that has increased over the years so that we do have more interdisciplinary research right now, but I'm wondering if we also need to look at bringing in some either leaders in these organizations or, it'd be wonderful to have some government officials on some of this research, just to build the constituencies for change. Does that sound way out?
Yeah.
Yep.
Yeah. So is the campaign involved in educating physicians while in medical school the role of NPs and evidence? That's a great question. The campaign and some of the leaders in the campaign have reached out to medical schools, to leaders. The Campaign for Action, our strategic advisory committee member was from the AAMC, right? Daryl. Greer. So, and I think that there are proponents for full practice authority, but Daryl Kirsch, thank you, Lynn. But the organizations aren't changing their positions, and they're spending a lot of money. So it's to get that changed. We do have some physicians that are more collaborative, that appreciate APRNs, but the party line for the American Medical Association, the American Association of Family Practices, physicians are the leaders of the team. But what I learned new in this webinar was the physicians as the leaders of the team puts them more at risk. So the nurse midwives have used that way of thinking in getting more collaborative relationships with OBGYNs. And Sandra asked a question about full practice authority in opioid treatment, and we're thrilled to have Joanne Spetz reply to see her paper in JAMA, and we'll add that. Joanne will add the full reference to the summary. What kind of DMP projects can positively impact the expansion of scope of practice in Florida? I think the DMP project would be what are the current barriers. Have there been, do I know of any CNS studies about CNS's prescribing? I have not seen that yet. I've seen studies about CNS's with outcomes towards shorter lengths of stay, lower rates of hospital-acquired infections. And regarding midwives, the California Healthcare Foundation will be publishing an evidence summary, so we'll look for that, and we'll add that to the written summary. Kevin, are there any more questions from the phone?
Yes, you do have a question from the line of Ashley Ritter.
Oh, hi, Ashley. Thank you.
Hi.
Thank you, and thank you for your research.
Oh, thank you very much. My question is in regard to, looking at state policy. Also has to consider the federal level policies and institutional level policies that can really interact to limit the ability of nurse practitioners to provide the best care in the settings that they are providing care. So this question is for Deanna Grimes and Dr. Braun. How do you envision engaging stakeholders specific to a setting? And has research looked at sort of the interaction of this tapestry of policies?
Well, I'll start, and I think that, well, we've got examples that are state nurses organizations. Researchers have presented information to the state boards, and they have lobbied for change. So I think it is a matter of moving the evidence up a bit, moving it away from, and I don't mean to emphasize this too much, but not only publishing it, but also taking bits and pieces. And I was thinking about what if we started a plan of writing letters to the local newspapers or that kind of thing to get it started. So, yes, we do have evidence that state boards of nurses have brought about change in the states. We're even seeing a tiny little bit of it in Texas. But I don't think we know. I don't think we have a plan for that. And I think that the evidence that the quality of care and the patient outcomes are equal and sometimes better than those provided directly by physicians, that information ought to be gotten out. And it ought to be gotten out also to our public so they could ask for a nurse practitioner when they go into a clinic, that they could seek out that level of care. Heather, do you got any thoughts?
Yeah, I mean, I think the other thing I think about, and thank you, Ashley, for calling in and asking about this. The work we focus on right now is thinking about kind of the state level scope. Well, what does that really mean at an individual practice and at the institution level, which I think was part of your question, and really thinking about the thoughtful. So in states that are broadening their scope of practice. You know, are there people within the institution, whether it's within leadership or APRNs who are themselves educated about these law changes to be able to then implement them in a consistent way so that you don't continue to see restrictions in scope that happen at an institutional level. In terms of kind of the practice environment, Lucine Pagosin has written extensively about that and kind of showing that when there are constraints at that organizational level, there are worse outcomes for NPs and for patients. So thinking about kind of other ways that we not only look at scope, but then how scope is kind of implemented in practices as well is important.
Thank you.
Okay. Thank you both. Kevin, any other more questions from the phone?
Yes. You do have a question from the line of Joanne Alderman.
Joanne, please go ahead.
Thank you very, very much. I've listened to this with great interest, and I am I love to listen to research. And I understand here that primary care is a concentration, as it should be, especially in our rural areas and our clinics, our hospitals, and our nursing homes and assisted living. My question is, what studies have been done in our skilled nursing unit, long-term care, and assisted living with the realm of practice and education from the CNS or NP, and do they have certification in gerontology, and does that medical director within that facility have his or her certification in gerontology, geriatrics? So those are some of the things I look at because I've been practicing in nursing homes as a CNS since '93 and been trying to change the outlook on our nursing homes for more education for our staff. And if a medical director is going to come in, then let's certainly have some certification, a certification in geriatrics. But there's no school here in the Midwest. It's on the East and on the West Coast. So I'm working to try to get that changed and have a university or universities take over that piece and have a place for our physicians to get their certification. So that's my question, Dr. Grimes. You're CNS and you're down in Texas. I might come down and see you because I could use some education. But these are my big questions. Are there any studies being done to look at our skilled nursing units and our long-term care and our assisted living facilities?
Well, I have to admit that I don't know of any of them right now. And I'll have to, I would do some searching to find out. But there's I think that's what's happened is in the research on APRNs and outcomes and cost, et cetera, that it's been a focus on the FNP, the family nurse practitioner, or the primary care. There's a few on geriatric nurse practitioners, but they're not recent. Now, maybe Heather is more familiar with what's in the works right now. But yeah, I'd love to have you come down and maybe we could develop something.
We might be able to, ma'am.
Yes.
So Joanne Spence replied in the chat regarding nursing homes. There's a research letter in Journal of the American Medical Directors Association about skilled nursing facility nursing director perspectives. The lead author is Laura Wagner, and the University of California, San Francisco Health Workforce Research Center on long-term care is now surveying medical directors on their medical staff organization, including employment of NPs and the organizational culture. And when I first started working at ARP, and shortly after the campaign, the Future of Nursing Report came out, we looked at seeing if we could change the federal policy to allow nurse practitioners and CNSs to be medical directors of skilled nursing facilities. And truth be told, when we reached out to the nursing organizations, there wasn't a lot of push for this. So I still think that's an area where nurses, advanced practice nurses, could step up. Keep looking at the chat. We're in a full practice state, but some of the hospitals, healthcare organizations limit what an APRN can do. Any advice? I would go with the cost factor.
Yeah.
When you're paying a physician for something that an APRN can do, you have excess costs. So if anything, any of the procedures that you could cost out would be the way to start. And also looking at organizations in similar organizations in your state, ideally, or in other states. And I believe a group at Braun University is looking at nurse practitioners and skilled nursing facilities, Dr. Elizabeth White. Kevin, any other questions on the phone?
There are no further questions at this time.
Okay. We have a few more minutes. We are going to take down the chat and provide more information in the call summary, and we may add more information to the handouts. No, there's no certifications. There's no CEUs. It's a free webinar. No CEUs. You can. We should go to the next slide. I want to tell you about the Campaign for Action. We have a lot of resources on the Campaign for Action website. Visit us on the web, and for webinar resources, we have a lot of slides, information on the access of care. Please follow us on Facebook and Twitter. And my email is abroussard@aarp.org. If you have specific information, if you have specific questions, we're always happy. Joanne Spence gave out her email, so she's always happy to provide more information about the work that she's doing. Thank you so much for joining us. I have a monthly Access to Care Learning Collaborative that is private. You have to sign up for it, so you need to contact me at abroussard@aarp.org if you would like to continued monthly call working on removing barriers to care. Like we said, this webinar is recorded, and we hope you'll continue to tune in. Thank you. And thank you to our presenters, Heather and Deanna, and if you would both stay on the speaker line. Otherwise, we're going to end the webinar.
Thank you so much.
Thank you.
This does conclude today's conference. You may now disconnect.
Okay.